Let's move on to our speakers tonight. Our first speaker is James Taylor. He's a professor of pediatrics at the UW School of Medicine and medical director of the newborn nursery. He is the director of the Pediatric Continuity Program at the UW and serves as the director of the Puget Sound Pediatric Research Network and co-managing director for the Better Outcomes Through Research in Newborns, or the BORN Network. Turning the page. His research interests, it's like, remind yourself. His research interests include immunization delivery, alternative therapies for children, and practice-based research. He's widely published. Most recently, he co-authored a study by Seattle Children's Research Institute that demonstrates the need for more research on the use of alternative immunization schedules and the safety and efficacy and consequences of delaying immunization. So I know some people are worried about their children getting vaccinations, and he's going to tell us what happens if you let that go. So I bring to you Dr. Taylor. It's my great pleasure.
So since I'm a pediatrician, I'm going to talk about childhood vaccines. And just for the discussion, for my part, I'm going to define a vaccine as a biologic agent that's administered to promote an immune response and treat or prevent disease. Vaccines are one of the few medical interventions that actually work. And that's kind of a funny thing to say, but if you think about all the therapies and the drugs that we use, most of them treat symptoms, might modify the disease a little bit, or control things. Vaccines are almost unique in their ability to almost 100% eliminate disease. It's one of the greatest public health interventions of all time, ranked by many people as the greatest public health measure other than clean water. It's really a triumph of the scientific method. And vaccines, because they are so successful, have now become a victim of their own success. Deaths from vaccine-preventable diseases have been reduced by greater than 99% with the introduction of effective immunization programs. And it's estimated that $20 is saved for every $1 spent on 9 childhood vaccines. So how did we get here? For really centuries, people knew about variolation, how to treat or prevent smallpox. And what this was you took some dried pus from a smallpox pustule on a victim, and then you inoculated that into the skin of healthy people. And this prevented smallpox. Now, many people got a mild to a moderate disease, and then it was estimated that 2 to 3% of people died from this vaccination, but it was somewhat effective. Then people, including Jenner in the late 1700s, began observing that there was a disease, cowpox, which produced some lesions, but not very much, that was similar to smallpox. And in fact, people who spent the most time around cowpox, milkmaids, didn't seem to get smallpox. And in fact, there's legend that the reason that we think milkmaids are so beautiful is because they had creamy complexion because they never had the disfiguring scars from smallpox. And so with this idea, people started using cowpox rather than really smallpox and inoculated that in people. And that was a very effective vaccination for smallpox. And the word vaccination actually comes from vaccinia, which is a name for smallpox. And then in 1881, Pasteur did research on the anthrax vaccine made using attenuated anthrax bacilli. And the main reason I put this in here is to show you an early example of a controlled experiment. And it's really pretty cool when you think about it. So what Pasteur did is he took 24 sheep, 1 goat, and 6 cows, and he gave them anthrax vaccine. And he took an equal number of animals, 24 sheep, 1 goat, and 6 cows, and they were the controls. And after the intervention animals had been vaccinated, he took both the intervention and control animals, and he administered virulent anthrax. And all the sheep and the goat died, who had been the control. None of the vaccinated animals died, and the only control animals that lived were the cows. and it was thought that the cows were too big to die. But anyway, this was a great demonstration of really how to conduct an experiment. In 1888, diphtheria toxin was discovered. And what investigators found was that if you took low doses of this toxin, and the toxin really was what produced the bad aspects of the disease, and if you took this toxin and injected into animals, they developed antitoxins. We now call those antibodies. And then you could use the serum from these animals, the antitoxins, to treat children who had diphtheria, and later they used the exact same principle for tetanus. And this idea of taking serum from animals who had been inoculated with the toxins, this immune serum, and administering to people was termed immunization. So here we have our two words that we sort of use synonymously now, vaccination and immunization. In 1923, they found out that formula inactivation of the diphtheria and tetanus toxins led to the development of toxoids. And a toxoid was something that looked like the toxin and made an immune response, but it really didn't cause much disease. And although this is really cool, the way they discovered it is like many things, they discovered it by accident. In a beaker where somebody had cleaned out with formalin to clean it, they poured some of the toxin in, and then they gave it to the animals and nothing happened, and they figured out that they'd left some of the formalin in the beaker, and that's really how they discovered that. But this idea of taking a toxin and treating it so it becomes still immunogenic, that is capable of producing immune response but not leading to disease, is really the basis of the vaccines we still use for diphtheria and tetanus. Also in the 20s, the whole cell pertussis vaccine was developed. Pertussis is what causes whooping cough. And so they took the whole bacteria and they killed it, and they administered that as an immunization. And the whole cell pertussis vaccine, it was combined with the diphtheria and the tetanus for the DTP or the DTP that was first licensed in 1948. And this vaccine was used up until the mid-90s when we developed a cellular pertussis vaccine. So that is not the whole part of the pertussis bacteria, but really just pieces of it. And that was capable of causing an immune response. And that was licensed as DT, and the A is for acellular pertussis. If you really want to read a fascinating story of medical history, read about the introduction of the polio vaccine. It really is. It's a compelling story. It combines everything in a great novel: politics, marketing, professional jealousy, triumphs, ethics, and ultimately triumph. In 1955, the IPV, inactivated poliovirus vaccine, was licensed for use in the United States with great fanfare. And it was a pretty effective vaccine. However, it wasn't nearly as good as the OPV, the oral polio vaccine, which was a live attenuated polio virus that we took by mouth. And the vast majority of you in the audience tonight were probably vaccinated with OPV. And we used OPV from the 60s until 2000, when in the United States we went back to the IPV, and it was at that time called the EIPV, for reasons that I'll talk about at the end. In the 1980s, we had the development of the HIB, the Haemophilus influenza type B, and the pneumococcal vaccines. Particularly the HIB vaccine was started as a polysaccharide vaccine, sugars that were part of the bacterial wall. And it turns out that the sugars by themselves didn't create much of an immune response, and it wasn't sustained. And so what they ended up doing is sticking the polysaccharide to proteins for improved efficacy. And then sort of the last development in vaccine production was the hepatitis B vaccine, which was the first recombinant vaccine. And they took the hepatitis B surface antigen, so a part of the virus, and cloned the gene for that into yeast and produced lots of the antigen for the vaccine. The new HPV vaccine uses a similar technique. So I've talked about lots of different ways for what we did to try to make biologic agents capable of producing immune response, so that you give immunity, but not hurt the individual. So we talked about attenuation. That's sort of letting the bacteria, the virus, grow, but in a way that it becomes less virulent. I put in question mark for small dosage. I don't really know why, when we first started giving people smallpox, why that worked, whether that was an attenuated because it had been sitting around or whether it was just a small dose. We've used killed and inactivated organisms. We've talked about inactivation of a toxin, used a small part, bits of an organism to cause an immune response, but it doesn't have the whole organism, so it can't make you sick, and cloning genes. So I'm going to now give a rudimentary discussion of vaccine immunology. And the reason it's rudimentary is because that's my level of understanding. And when they were talking about me at the beginning, I do health services research. So some of you might know more about this than I do. But just a few terminologies, a few terms. An antigen is a substance that leads to an immune response and production of antibody. And this might be materials on the walls of a bacteria or toxins produced by the bacteria or pieces of a virus. And an antibody is a protein produced by the body to attach to an antigen and lead to its destruction. Lymphocytes are a type of white blood cells. They differentiate into cells with multiple functions. B lymphocytes are involved in the production of antibodies, and T lymphocytes are crucial in promoting an immune process and involved in the destructions of antigens. The terms, you all might be familiar with all those terms. Something you might not be familiar with is the innate immune system. And this is sort of the non-specific response to foreign antigens. It initiates the immune response. When you get an infection or you get a vaccine, the first thing that happens is activation of the innate immune system. So vaccine-induced immunity is really a complicated process. And for the vast majority of the time that I was talking about the histories of vaccines, we didn't know how they worked. It was just sort of a empiric, we did it and they got better. But slowly we're starting to understand it, and whatever I'm telling you tonight, 5 years from now they're going to tell you it was wrong because we continually figure out more, and it's always more complicated than we thought previously. And it turns out that different kinds of vaccines are more or less able to produce a good immune response. So the best vaccines are the live attenuated virus. So you've got the real virus in there, and it's just attenuating so it can't cause disease, but it acts in other ways like the regular virus. As we talked about the polysaccharide vaccines made with the sugars, they need protein conjugates to really initiate a sustained response. Adjuvants are things that are added to many of the non-live vaccines to really increase the immune response. There are four main steps in the process of vaccine-induced immunity. First is activation of the innate immune system after the administration of the vaccine. Next, you get production of the primary antibody response. Then after a booster dose, you get an increased magnitude of the response. And ultimately, what you hope for are memory B cells, which live and sort of allow for long-term immunity to disease. Dendritic cells are specialized white cells that contain receptors that differentiate new antigens from self-antigens. And so the easiest way to think about a dendritic cell is it has a receptor on there that's sort of the generic receptor. It's sort of like it knows what you are and knows that that's not anything bad, but if it sees sort of generic parts of bacteria or viruses, it says, that's not right. And so when you get a vaccine, if there's enough antigen in there, your body sends out danger signals. Okay, we got a new antigen here. And the first thing that happens is it activates the dendritic cells. The dendritic cells come to the site of the vaccine and attach to the antigens and then migrate to the lymph nodes with the antigens. In the lymph nodes, the B cells are activated and they begin the process of developing specific antibodies to the antigen. So the dendritic cells are sort of non-specific, and then you start making specific antibodies to that antigen. And then the B cells differentiate into plasma cells, which can produce large amounts of antibody. And then other B cells become the memory cells, which can differentiate into plasma cells if they're re-exposed to the antigen. Then the memory B cells are really where you get your long-term immunity. So, as I said, live attenuated vaccines produce the most vigorous response, and they really, lots of times you don't need any boosting with a live attenuated vaccine. So like MMR, measles, mumps, and rubella, German measles. We used to just give that once because those are all live attenuated viruses, and the idea was that you were going to get lifelong immunity with it. What we're finding out is actually over time, slowly, your immunity to those diseases decreases, and that's why now there's a booster shot for MMR. The non-live vaccines usually require multiple doses to maximize the primary response, and then booster doses to give prolonged immunity. So if you want to understand the generic vaccine schedule, when you get the first primary response, the first vaccine dose, that sort of your immune response peaks at about 30 days and then goes down. And we found out if you give a second dose right at that peak of that or close to that, then you're going to get a bump in that. And then you wait for that primary response to go down, which takes 4 to 6 months. And then if you get a booster dose, you get a huge increase in antibody production, and then you get immunity that lasts for a long time. And that really, with modifications, is sort of the generic vaccine schedule. I graduated from medical school in 1980, and vaccines were kind of boring. You didn't think much was going on, and there really wasn't very much. But since the 1980s, there's really been an explosion, and vaccines became much more interesting, much more important for pediatricians to know about, and a lot more controversial. So four main things happened that I want to talk about. One was the explosion of new vaccines were licensed and then mandated, meaning that to go to school you had to have these vaccines. with both the old vaccines that we had and the new ones, there was the virtual elimination of many vaccine-preventable diseases, both in the United States and elsewhere. That was a good thing. The bad things were we had this realization that even though we had good vaccines, not everybody was vaccinated. And that was sort of surprising. And then, as we had less and less vaccine-preventable disease, people started worrying more about the side effects and the disease, and that's when we had the rise of vaccine controversies. So my children were born in 1979 and 1980. Life was easy when you were a baby in 1980. To be fully vaccinated by the time you were 2 years old, you needed 4 DPTs, 1 MMR, 3 oral polios, and you're done. Total of 5 shots. So a baby born today, my 13-month-old grandson, for him to be fully vaccinated by the time he's 2, he's going to need 4 DTaPs, 1 MMR, 3 IPVs, 3 hepatitis Bs, 2 hepatitis As, 4 Haemophilus type B vaccines, 4 pneumococcal vaccines, 1 varicella vaccine. That should be 3 oral rotavirus vaccines. That's rotavirus causes diarrhea. And so that's a total of 23 shots. Now, there's a huge industry of trying to combine antigens into different shots, and it's a lot more complicated than you might think, but they have been successful in combining some vaccines, so you can reduce the number of injections from 23 to down to about 12. But it's a lot more than 5, and so it's a lot tougher to be a baby now in many ways. However, it's a lot better to be a baby in many ways too. So here's sort of the old vaccines and how much disease we've reduced in the United States. So for the Pertussis vaccine, compared to before we had the vaccine, in 2007, there were 10,000 cases, so a 93% reduction. For polio, polio was gone in the United States, 100% reduction. Measles, greater than 99% reduction. Mumps, greater than 99% reduction. Congenital rubella, so with rubella, the disease itself is not that bad. Who really gets it bad are babies born with congenital rubella. There's no cases of congenital rubella in 2007. Well, how about the new vaccines? In my career, by far the biggest advance in pediatrics was the introduction of the Haemophilus influenza type B vaccine. When I was a resident in the early 80s, on our service there was always at least one and multiple times tons, not tons, 3 or 4 babies with H. flu meningitis. It was a terrible disease. The babies were really sick. A lot of them had bad sequelae. A lot of them died. The residents at children's hospitals now, never seen a case. And it's really remarkable. So it went from 20,000 to 0. 22 they had. There's a little bit still out there, mostly because people don't get vaccinated. So greater than a 99% reduction. Invasive pneumococcal disease has been reduced by 77%. And varicella chickenpox, we don't think of chickenpox as being a bad disease, but they're the rare complications, and we've reduced deaths from varicella with the vaccine by 87%. It turns out you don't need to have a 100% vaccination rate to really prevent infectious diseases from vaccine-preventable diseases. And that's because of the concept of herd immunity. That's the idea that if enough people in a population are immunized, there's not enough people to propagate an epidemic. That if one person gets it, he or she's not going to be exposed to enough susceptible people to propagate the epidemic. This was really demonstrated well with varicella vaccine. And a good study in North Carolina daycares. I like to talk about this because I'm from North Carolina. And in 1995, when the vaccine was being rolled out, about 4% of the children in these daycares were immunized against varicella. By 1999, it was 63%. So it came up a lot, but not even close to 100%. The people that got vaccinated, of course, their risk of disease dropped, like you would predict, dramatically. But it turns out the children in the daycare who weren't vaccinated, their chance of getting chickenpox also went down by 91%. And that's totally because herd immunity. There was enough kids vaccinated in the daycare center that there just wasn't enough left to propagate an epidemic. And so in the United States, for most antigens for childhood diseases, the uptake is 80 to 90%. Some are more than 90%. And so that sounds really good. However, if there are pockets where even if the whole population is 80, 90%, but there's a population that is like less than a magic number, 40, 50, 60%, then you've got a chance of having an epidemic. And that's exactly what happened with measles in the late 80s. In the early 80s, there were about less than 5,000 cases a year of measles. In 1989, there were 18,000 cases and 41 deaths. 1990, there were 25,000 cases and 60 deaths. And unlike previous sort of outbreaks of measles, the majority of these cases were in children less than 5 years old. And not only that, most of the children affected were sort of minority children living in inner cities of certain big cities in the United States. Chicago and LA had a really disproportionate number of cases. And it turns out that even though the vaccination rate for measles across the country was probably pretty good, in these areas the vaccination rate for measles was under 50% in a lot of these areas. And I think that came to a real surprise, although it doesn't seems like that's sort of duh. I think people were really surprised that, we've got this really good vaccine for MMR, why isn't everybody immunized? And it was really a realization that it's not only making a good vaccine, but it's actually the delivery system for that vaccine that makes an effective immunization program. So there's a lot of hand-wringing and gnashing of teeth, and the experts got together and they released the Standards for Pediatric Immunization Practices in 1993. And they had, I think there were 18 of them, 18 specific recommendations. Some of these dealt with how vaccines are handled and processed and all these kind of things. But they had a few specific recommendations to increase immunization rates in the United States. They recommended that we remove the financial and systematic barriers to immunizations. The financial barriers, it's easy to understand. The systematic barriers is we should make it easier for parents to have their kids immunized. You shouldn't just say you got to get your shots 9 to 1 on Tuesdays. You know, you got to expand hours. You shouldn't link vaccines with well child care checks, things like that. That we should actually assess the immunization status of children frequently. It's sort of staggering, but it's hard to find an overall estimate of vaccine rates in the United States before 1990. Then they also had a lot of interventions aimed at providers, people who give immunizations, pediatricians. And some of the recommendations that I'm going to talk about are limit missed opportunities, only follow true contraindications to not vaccinating children, give all vaccines for which a child is eligible at a visit, and reminder recall systems. So what actually works to increase immunizations? Well, probably the best thing is the simplest and the oldest, and that's mandates for school and daycare. So in every state, there's a mandate that you get all your vaccines, or a specific set of vaccines, before you can go to school, and most of them there's before you can go to daycare. Now, there are exemptions, religious, and in some states, there's philosophic exemptions that I'll talk about. But you can show that mandated, if you introduce a vaccine and you mandate it, the immunization rate goes way up, just like you'd predict. One of the things we did in the 90s is we really worked hard to remove the financial burden of getting a child immunized. When I was in private practice in the 80s, if you came in for your shots, you paid for them out of pocket. Your insurance didn't cover it. And it was really only in the 90s when lots of insurance programs were either mandated or did it voluntarily, where that was for immunizations were covered as part of a health insurance package. For people who didn't have insurance, who couldn't afford insurance, disadvantaged children, there was the Vaccine for Children's program, which was introduced was passed and is a federal program starting in the mid-90s. So this is a way for people who can't pay for vaccines to get them. And then some states are what's called a universal purchase state. Washington is one of the remaining, and they're sort of dwindling, universal purchase state. So the Department of Health for Washington buys a bunch of vaccines, and then they give it to providers to use for free. And the providers can't charge patients for the vaccine. They can only charge an administration fee, and that administration fee is set. So we've really done a lot to try to remove the financial burden. Well, as I said, a lot of the interventions around trying to increase immunizations dealt with providers. And because there was sort of a growing notion that providers in a practice are responsible for the immunization status of the children they provide care for. In the late 80s, it was estimated that about 50% of shots were given in the public sector and then 50% given in primary care offices. By 1997, that was 73%. I don't have any more recent number. My guess is it's higher still now. Well, what are the things that providers can do to increase immunizations of the children in their practice? Well, a big thing that you heard a lot of was missed opportunities. This is the idea that don't just use a visit for a checkup to immunize kids. When a child comes in for a cold, look at their shot records. If they're behind, you give them a shot then. It was sort of the poster child for what providers were supposed to do. Unfortunately, when people studied it, it didn't work. And probably the reason it works, I don't think anybody knows why it doesn't work, but probably if you look at the immunization schedule, it is really complicated and really regimented. And I think what happens is once you get kids off that schedule and your office sort of loses that regimentation, you sort of get chaos and things don't work as well. What we do know is limiting contraindications is very effective. So there's only 1 or 2 contraindications for each vaccine, and there's only a tiny percentage of kids that qualify for those contraindications. But then some people say, well, a cold, if a child comes in and he's got a cold, can't vaccinate him. And in fact, if you list a bunch of potential contraindications and ask providers to pick how many of these are contraindications, the more they pick, the lower the immunization rate is for their practice. There is some evidence, it's not fantastic, that actually providing all the vaccines for which a child is eligible at the visit, like a health supervision visit, is effective. So if a child comes in at 6 months and he's eligible for 4 shots, if you give him 4 shots, that's better than saying, okay, we're going to give him 1 now and we don't want him to have, let's have another one in 2 weeks. And there is finally some limited evidence that reminder recall systems work. That is a thing where you have some list in your office and you say, okay, when this person gets to be 6 months old, we're going to tell his parents it's time to come in and get a vaccine. Kind of like most dentists do. We're way behind the dentists. All righty. So we talked about things we did to remove the financial barriers. We talked about provider interventions. What about other systematic barriers to immunization? You used to hear a lot about that. So in the late 90s, in a study that we published in 2000, I was involved in a project where we surveyed 13,000 parents. That is a bad thing. It's 13,446 parents who were seen in private practices and clinic practices in the United States, primary care practices. And we asked the parents, what were the barriers of getting your child immunized? 70% of people says there weren't any barriers. But then a small percentage said that we gave them a list and they picked them. So about 4% of people said the confusing vaccine schedule was a barrier for getting their child vaccinated. 2% said the expensive vaccines were a barrier. About 5% inconvenience. Having a child too ill, the child that's got the cold, 3%. Religious objections, 0.2%. And look at that, 22.7% of people said the worry about side effects was a barrier to getting their child immunized. Well, how did these perceived barriers play out in terms of the immunization status of their children? Well, it turns out, if you said you were concerned about the confusing vaccine schedule, that was a barrier, your child was 1.46 times, 46% less likely to be, 46% more likely to be under-immunized than if you didn't select that as a barrier. And you can see the other ones listed here, the expensive vaccines, inconvenience of the vaccine process. If you said your child was frequently too ill to receive vaccines and that was a barrier, where your child was twice as likely to be unvaccinated as if you didn't say that was a barrier. Religious objections even higher at 3 times. And here, concern about side effects. Even though lots of people were concerned about side effects, it didn't seem to really keep them from immunizing their children. That NS means non-significant. Now, just relative risk, everybody talks about relative risk or odd ratios a lot, and they can sort of be, the old thing, figures don't lie, but liars sure can figure. Relative risk are a way that we can so people can really exaggerate things sometimes. A number that I really like, or a concept, is populational attributable risk percent, PAR percent. What that means is how much, for this example, how much under-immunization is related to each one of these factors. So if you said the vaccine schedule was confusing and that was a barrier, that contributed to 1.6% of the under-immunization in our study. So not very much. And in fact, if you add up all these things, it only added up to 8% of the under-immunization. So we really showed that parental barriers or perception of barriers really weren't a big impediment to getting your child immunized. Well, what happened with all these things we tried to do? In fact, the immunization rate went up in the United States. In 1992, it was 55%. That's pathetically bad. And this rose, and by 2005, it was 83%. So not fantastic, but we're doing pretty well. And then by 2010, it's 78%. Now, the reason there's an asterisk by the 78% is because it took more and more vaccines as new vaccines were licensed to be considered fully immunized. So I think it's like 15 vaccines you had to receive 15 vaccines in 2010 compared to 5 in 92. So, we've made some progress, still have some room to go. Why do you decide to get vaccines for your child? Or why do you get any preventive service? It turns out I like this health belief model where an individual or parent balances all these things to decide whether to get the preventive service. And those are perceived susceptibility, severity of the disease is prevented, the perceived benefit of preventive service, the barriers to getting to preventive services, and the perceived self-efficacy. That is that I'm responsible, I can overcome barriers to get the service or not get the service. So if you think about my parents, I was born in 1954. Polio vaccine was licensed in 1955. So think about what they would go through to make the decision for whether to get that for me. Well, perceived susceptibility. My older sister had polio. They knew it could happen. Severity, disease prevented. Well, there's 16,000 cases. That's a lot. My parents' best friend was in a wheelchair because she had polio. So that's pretty big. Perceived benefit. Well, we think the shot's going to work. Well, that sounds good. The barriers. I don't think we really we're worried about the side effects in 1955. You know, if it made you sick, it must be good, strong medicine, you know. And, or the inconvenience, it really didn't seem like that much. And the perceived self-efficacy, you know, my parents could figure out, okay, this is where we go to get the shot. We got to be there at 2 o'clock, you know, blah, blah, blah. So it's kind of a no-brainer using that model that they would take their baby to get the shot. And in fact, I think that's what happened. But there's a sort of rising controversies about vaccines. And I said the vaccines are controversial since 1885. It's probably before that. That was in vaccine controversy in 1885 was about the rabies vaccine. But sort of since the 1970s, in particular since the new millennium, there's been growing concern by some people about vaccine safety. In 2000, 19 to 22% of parents were worried about safety. 2004, 30% were worried. Numbers are probably higher now. It's estimated that the overall contribution to under-immunization because of parental concerns of vaccine safety is about 2 to 5%. Well, what are some vaccine safety issues? And I'm just going to pick 4 to sort of highlight this. There's the Pertussis vaccine encephalopathy. The one that you all probably know the most about is Mmr and Autism. Thimerosal and a multitude of problems it was supposed to cause, and VAP, or vaccine-associated paralytic polio. So, we talked about the DPT vaccine, the original one being whole cell. There's a whole lot of junk in there, and it really caused a lot of side effects. About half the children that got the old DTP got fever. So even though my children didn't get many vaccines, they got the bad ones. And fever to 105 was about 1%. You know, redness, 37%, anorexia, loss of appetite, 21%. Persistent crying for a prolonged period of time after the vaccine, 3%. And the 2 that were really frightening to people were unusual high-pitched cry and these things called hypotonic hyperresponsive episode where the child would just sort of lie there lifelessly for a long time. And when those 2 things, people said, there must be something bad going on in the baby's brain to have that. So in fact, people were worried about pertussis vaccine encephalopathy. It was first reported in 1948, which was surprised the year the vaccine first came out, well, with the DTP. In the 1970s, it became multiple reports of this pertussis encephalopathy, that you got brain damage after the pertussis vaccine. There are television shows about it. And in fact, the English, who were very concerned about it, they did the study, and there was one study, and one study only, that estimated that the incidence of this pertussis vaccine encephalopathy was 1 in 310,000 children who were vaccinated. So what happened? People quit getting the shots. And there were multiple epidemics and deaths related to pertussis when the immunization rate fell in the 70s in Japan and England. And at that time, people calculated that even if these neurologic effects of DTP were true, the rates of neurologic disease or death were higher from the disease than from the vaccine. And so to get a neurologic illness, it's not that great. You know, 4 to 1, that's not that good a ratio, really. And death, 19 to 1. Well, it was because, in large part, because of the concerns about both the reactogenicity of the vaccine, the sort of the nuisance side effect, and this concern about possible vaccine encephalopathy, that work began to have an acellular vaccine. And so this is just parts of the pertussis bacteria, and that was the DTAP was licensed in the early 90s, and that's all we use now, and you don't hear much about this. It turns out in retrospect, when people have gone back to look at it, that they really can't find any real evidence that there was a such thing as pertussis vaccine encephalopathy. Well, how about MMR and autism? So this is really famous. In 1998, Wakefield and his colleagues published a paper in Lancet, which is a very prestigious English journal, and they described 12 children who developed colitis, diarrhea, and had recessive autism around 1 to 2 weeks after receiving the MMR. These children were reportedly to be developmentally normal to the vaccination. So here you had a kid who was normal, and 1 or 2 weeks after he got the MMR, he was supposed to have, developing signs of autism. Well, there's been a whole lot written about this, and it turns out that there were lots of irregularities in this research. 3 of the 9 patients that were described as having autism actually didn't have autism. Many of the children of these 12 who were described as developmentally normal before the vaccine were not. Symptoms in some of the children didn't appear until several months after the vaccination rather than right away. And the biggest and sort of most damning at all is that the study was commissioned and funded to support anti-vaccine litigation. The long and the short of it is Lancet, I don't know, maybe a year or two ago, retracted the article. Most of the authors said they didn't want to have anything to do with it, and Wakefield actually lost his license. So it has been a huge event in sort of in how we look at literature, medical literature and stuff. Does MMR cause autism? In 2001, the U.S. Institute of Medicine reviewed the evidence and said they could not find a causal link. There have been lots of other studies tried to duplicate what Wakefield and his colleagues done, and really nobody could duplicate that in any kind of rigorous manner. In fact, there's pretty good evidence that MMR doesn't cause autism. Well, despite sort of things, people were questioning this research from the start, but in England, rates for MMR vaccine fell as this publicity came out. A large proportion of the cases were reported in London, and London turned out to have a lower MMR vaccine rate to begin with, and it dropped more when all the publicity came out about the vaccine safety issue. In certain ethnic groups in London, the rates fell to less than 60%, and that sort of gets you below the magic number where you might start getting some cases. So it turned out here that if you look at measles in England and Wales between 1995 and 2010, you can sort of see it's a pretty low level. Sort of peaks a little bit after the first wave of publicity about this comes out, and then there's a big increase, peaking at about 1,000 cases in 2008, and then it's fallen back with lots of efforts to get children immunized against measles and MMR in England. Well, why is there so much publicity, and why is there so much scare about sort of non-scientific vaccine safety issues? The biggest one, and this is a sort of an important thing about all pediatric epidemiology, is true, and unrelated. Children get a lot of vaccines their first 2 years of life. A lot of things happen to children the first 2 years of life. It is very easy for two things to be temporally related that aren't cause and effect, but that's hard to sort out. And so it turns out when you have your scare, it's sensational. Wakefield had a big press conference when he announced his study. But then the rigorous studies, which are to either replicate or refute these findings, come out. It's kind of boring and nobody pays attention. Stories trump epidemiology. You know, the story of this, I took my child and she was perfect, and then this is what happened to her. Those are really powerful for all of us, and they really are more powerful than sort of numbers. We have experience in our lifetime that the government doesn't always tell us the truth. So just because the government tells us something, we're skeptical. And then finally, another reason we're skeptical is because we know that money corrupts. And there's a lot of money involved in vaccine development. And so if you balance all those things out, it's not surprising that people are really concerned about vaccines, even when the scientific evidence doesn't seem to support whatever the particular scare is. So here's a theoretical scare, thimerosal. So thimerosal is a mercury compound, and it was used as a preservative in vaccines to prevent bacterial contamination. So it gets a little bit convoluted here, but ethyl mercury is a metabolite of thimerosal, and we didn't have a whole lot of data on ethyl mercury causing problems, but it's related to methyl mercury, and there was some evidence to suggest that small doses, a cumulative effect of methyl mercury could lead to subtle neurodevelopmental abnormalities. One bad problem when we only gave 5 shots, 2 years, but how not when we're given 23? It turns out that as you gave more vaccines that all had thimerosal in them, the amount of thimerosal would increase. And so the EPA had sort of maximal safe limits of exposure to methyl mercury. And in the first 6 months of life, depending on how much a child weighed, it was from 65 to 106 micrograms. Now, the FDA and the WHO and other organizations had much higher limits. But if you use that EPA definition of what this is a maximum safe dose of mercury, and then you say, well, how much mercury will kids get from thimerosal and vaccines in the first 6 months of life? Well, it turned out if you got the maximum dose, it was 187.5 micrograms. So it was more than what the EPA said was definitely safe. So this led to a big deal. In 1999, the recommendation came out that thimerosal be reduced or eliminated from vaccines, and childhood vaccines now contain no or minimal doses of thimerosal. In retrospect, there's no evidence that thimerosal in there caused any problems, and there's no evidence that thimerosal increases the risk of autism, or you can put blank and you can put whatever, but if you go to the internet, you'll find, you know, a million hits for thimerosal causing problems. And now here's a real vaccine safety issue, and that's VAP, vaccine-associated paralytic polio. It turns out that the oral polio vaccine is incredibly effective. The last outbreak of paralytic polio in the United States was 1979. In 1994, the whole Western Hemisphere was considered to be, quote, wild-type polio virus-free. That means there was no wild-type polio left. I just read something not so long ago, maybe you all saw it, about something in India had a lot of cases, and they've actually had a very effective program, and they've done a great job of lowering the rate of polio. There is this worldwide goal of eliminating polio. It used to be 2000, maybe it's 2010, I think it's 2020 now. So we about got rid of polio in the United States, except from the vaccine. And between 1980 and 1996, there were about 8 to 10 cases a year of vaccine-associated paralytic polio. That means people got paralytic polio from the vaccine. And it's a live, attenuated vaccine. It's not supposed to be virulent. But in somebody who was immunocompromised, who didn't have a good immune system, a little baby, you could get the disease. Since you ingest the way the virus works is you would take it orally, and it would come out in your stool. And if somebody was changing your diapers, and then they got some on their fingers, and they ate it, and they were immunocompromised, they could get vaccine-associated paralytic polio too, and that happened. So most of the cases were in immunocompromised people, but it did occur in immunocompetent individuals too. So now we had a situation we had virtually no disease except from the vaccine. And so in 2000, the U.S. switched back to, was actually in the late 90s, and by 2000 it was almost exclusive, I think it was exclusively injectable polio or inactivated polio vaccine again. So we sort of went from things that were, there's not a lot of evidence, to thimerosal, which is a kind of theoretical thing, to this that was truly a vaccine safety issue. Well, here we started with the preventive model for, the health belief model for preventive services. So I told you what it's like in the mid-50s. So what is it like for a parent now in 2012? Well, perceived susceptibility. Most parents never seen any of these diseases, never seen a case of H. flu meningitis. I mean, the doctors, the pediatricians haven't. So they're not sure their child's susceptible. They don't know anything about the severity of disease. They've never seen somebody in a wheelchair for polio. And so the perceived benefit may not be there. But what they do know a lot about is the concerns about safety, the side effects, the inconvenience. So that's come more to the front. And they actually, parents have a lot of self-efficacy. They don't have to listen to what I tell them. They can go to the internet and find out the truth. And so, so they have a lot of self-efficacy about, decide whether or not to get their child immunized. Well, what happens? There is growing resistance to vaccines. Here is Washington State exemption rates. So you're supposed to get all your vaccines, and you can have a religious objection to getting vaccinated to go to school, or you can take a personal exemption from being vaccinated because of your personal beliefs. In 2003 school year, 3.6% of children who entered school, parents took that personal exemption, and it's risen now to almost 7%, 6.8% in 2008. We are number one in the country. The national mean is 2%. Some states are, I think there's 2 states now where you can't take personal exemptions for immunizations. So we have a high rate of personal exemptions, and we have a fair amount of vaccine resistance at Washington State, and we're currently 46th out of 50th in immunization rates in Washington. So we're supposed to talk about what's down the road, and I talk totally about what's gone on. So I will end with my crystal ball to tell you what's down the road in pediatric vaccines. I think it's inevitable that there's going to be increasing parental concerns about vaccines. And people, policymakers, are actually quite worried that there's going to be locations where there's going to be a pocket of people who really have really low immunization rates, and we're going to see the reemergence of some vaccine-preventable diseases. One of the things that's going to make it better and better to figure out if somebody says the vaccine causes X, Y, or Z, we'll have a lot better way of finding out about rare events. And that's with electronic medical records or these databases or registries. It's a whole lot easier than it used to be to link together huge numbers of records and try to separate whether this event was really linked to a vaccine or not. And finally, we're going to have more vaccines. The meningococcal vaccine for infants would be a really good thing. There is a meningococcal vaccine for older children and adults, but it turns out the biggest risk for meningococcal disease is in infants. And the reason people have tried a lot of different things, but it just turns out that certain serotypes, some of the types of the meningococcus that cause disease the most, they have a hard time so far getting children the amount of immune response. And then I don't know if you all saw it, but there was recently an article in the New England Journal about a malaria vaccine that's being developed and was tested in Africa. And it really some fairly heartening results with that. And that would be a huge thing in much of the world if we got an effective vaccine for malaria. Thank you.